Hi everyone and welcome to the ANGIE podcast, where we discuss issues around targeted drug delivery and nanomedicine. I'm Vliora, a molecular biologist, and I will be your host today. Aside from all the technical issues around targeted drug delivery and nanomedicine, there are also a lot of social issues that are rising, with one of them being inequalities in health. Well, inequalities in health exist without the concept of nanomedicine already, so it would be nice to have an opinion of an expert on how this will affect the already existing problem. Today I'm really happy to discuss this topic with Dr. Vasiliki Petousi, Professor of Sociology of Law and Deviance in the Department of Sociology of University of Crete and Director of the Gender Lab. Nice to have you here with us, Professor.
Thank you very much for the invitation.
So, to start with, would you like to give us some background of yourself?
Well, I'm teaching sociology of law, deviance, criminological theory, feminist theory, and I have been involved in the bioethics graduate program for a long time, where I teach research ethics, and I teach also issues of assisted reproduction. And the other thing that I've been involved is in research on research integrity and ethics I've served as an ethics expert for the European Commission, ethics committees in Greece, and ethics advisor in several EU-funded projects.
Great. So, to start our discussion, would you like to give us your perspective on what are the primary social determinants of health that contribute to inequalities in health outcomes?
I will start with what we consider not to be like a standard definition, that of the World Health Organization, that social determinants of health are non-medical factors that influence health outcomes. Those are conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. When we talk about determinants, of course, we imply causality, a causal link between these conditions, the ones we said before, and people's health. Actually, there are estimates that show that the contribution of sectors outside health to population health outcomes exceeds the contribution from the health sector. The next thing to see here is what makes a determinant social. Human behavior is social because we as humans engage in a social system of interactions with other humans, and within a social framework of institutions, roles, statuses, rules, and also a culture of values, symbols, ideologies. And here we should include religion, science, popular beliefs that shape and rationalize societal organization. That's why we're human. Now, a relevant question here to pause is, how do social relations in society become literally, in the case of social determinants of health, embodied, incorporated, and these result in pathology? So this is a question, and the answer to this question helps us understand how social determinants of health impact people's health. Now, social determinants of health are social because they're formed and shaped within those social systems. And societal systems include governments, institutions, organizations, regulation, processes. And there, in this system, these systems actually control resources and hazards for health. They allocate, they withhold, they distribute food, for example, or lack of food, shelter, safety, danger, civic participation, education, employment, all these things, law, justice, all these things occur within societal systems. Additionally, the health consequences of social determinants of health are also social. As the result of the social determinants of health, these are social because, for example, see, if a person is diagnosed with cancer, they have, they're depressed or they lose sleep or they eat less or whatever. See, for example, how it works in Greece. An example that most, or I would say, a major factor in the significant problem of traffic accidents we have is related to lifestyle, to people's way of driving. We know, for example, that most or the majority of victims in lethal traffic accidents are young men, or they're new, relatively young drivers. So if we see all these contexts, then it's easy to understand that if societal social systems are based on inequalities, social determinants of health will result in health inequalities because they're structured around inequalities. And what we have as critical components there are those divides and categories of humanity. We divide people into demographic categories such as sex, gender, race, class, all these. But within these categorizations, these categories, what we experience is differences in power and differences in societal resources. This process of allocation frames society's inequalities and equity. And to the extent, again, that we are locating social determinants of health in this, we end up with inequalities. The positive aspect here is that none of these categories of person, nor the allocations of resources and power, are stable and constant. As a matter of fact, they're invented and reinvented constantly. They evolve, they change, and it's been transformed. So we can change things in inequalities.
That is very interesting, that the point that we have the power to make the change. But as of now, there are a lot of factors that can influence the health outcomes across different communities. How do you think that the socioeconomic factors like income, education, gender, or sex can impact the health outcomes across the different communities?
Inequalities usually are what we say interwoven. They're interrelated. There's intersectionality in differences. So a person with a low socioeconomic status, a low education, has less resources and all that. So depending on the group that you're in, you may have more or less inequality, you experience inequality, or different forms of inequality. In gender, for example, when we have gender differences, and we have gender differences as a result of gender hierarchy, right? But gender differences is a constant for many social phenomena, including health. We know, for example, that wherever we look, we'll find gender differences. What we know, though, is that there exists significant knowledge and research gaps in relation to women's health. There's plenty of research that shows that the design and the execution of studies, for example, are gender biased for a variety of reasons, one of which appears to be the assumption that the male body is the prototypical body, the prototypical human body, and that research findings for this body can be extrapolated to women's body. This is not the case. But here, however, the same holds true for other bodies. When we talk about male bodies, the body of what male are we talking about? And when we talk about women's bodies, which women do we have in mind? The old, the young, the rich, the poor, the rural, the urban. All these factors that result in inequalities are written on our bodies and affect our health, our behavior, our beliefs, all these, our way of life. So these, if we want to make a contribution, then we have to take all these differences into account. Targeted drug delivery, for example, has the potential to address these differences, but only if this difference is taken into account in all the stages, the design, the development, the delivery of any and all innovations.
In what ways do you think that racial and ethnic disparities can shape access to healthcare and overall health outcomes?
They're very significant contributors to inequalities. If we have, as we do have, power differentials in races, in economic distribution and all these different hierarchies affect whether we have access or we can afford healthcare. Not only when we're ill, but even in the conditions before that. For example, we know that people with lower socioeconomic status tend to be overweight, or they're more likely to be overweight. They go to seek medical health at a later stage, and then the illness has progressed more. They cannot afford preventive examinations, for example, right? So all these contribute to inequalities. The other thing that is related here is that in research, for example, we may not take into account racial differences. We may forget to look at racial differences.
So these were the social determinants of health. And I would like to move on to the section of targeted drug delivery, which is an emerging area in medicine that involves designing treatments to directly target specific cells, often making them more effective. And of course, this results in reduced side effects. Are you familiar with this concept, and what are your initial thoughts on it, on the social point of view?
I do have a general knowledge of it. I mean, I understand the concept. I don't know the workings of it, of course, but I understand the concept of it, and I understand how it can benefit individual and public health. I believe it's an excellent opportunity, a tool to alleviate pain and suffering, increase health outcomes. For me, it's a very welcome development, but on the conditions of accessibility and affordability.
Okay, so how do you think that the advancement of targeted drug delivery can impact healthcare access or treatment effectiveness across genders or different social groups?
If equity is prioritized, if it becomes a principle, an operating principle for the delivery or for the development and the delivery of this medical innovation, then we will enhance equality and benefits across different social groups. If we do not have prioritized equity over profit or power, then we will only enhance inequalities, because we will exclude even more people who might need this new medical technology even more. As people who are marginalized, for example, and discriminated against, they might have more need of targeted drug delivery than people who have overall a better health, for example, or have access to better health care. Will that be available to these people? It's a question that we have to think about as a society, okay, as a priority.
Yeah, and it actually brings me to my next question. Targeted drug delivery often requires advanced technology and specialized healthcare providers. Do you think that this will be affecting the availability of such treatments in under-resourced communities in the future?
Yes, I think it will. Again, it will depend on economic and political decisions and the priorities. If we don't, for example, give public money to develop targeted drug delivery, right? If we don't give public money that will then be spent to the development and the distribution of this technology, the under-resourced communities will not be able to support that, to afford this new technology. So what are we doing if we're not supporting under-resourced communities? We are contributing to enhancing the health of the healthy or the health of the rich and the powerful. Is that the goal of the medical innovation? It's something that not only governments and policymakers, but scientists themselves have to think about. Why am I developing this? How am I developing this innovation? Why do I care to do research in this area? I know it's exciting. I understand it's exciting. Of course, I do research in this area because I can do it and it's fun and it's challenging. But how is this research going to be used? We need to think about that as well.
So from a sociological standpoint, do you find that there are any other ethical issues that arise when only certain groups can afford or access treatments like targeted drug delivery?
Let's start with the argument that it's not an argument, it's a thesis that health is a basic human right. And it is a basic human right because it's a right for all. But this right includes universal access to timely, acceptable, affordable health care of appropriate quality. If these conditions are not met, then we don't meet the conditions of social justice. And people's fundamental rights are violated. It's as simple as that. Then justice, security, health, aren't these supposed to be fundamental in our societies? It's a question now. Are these? We need to wonder and we need to act on these questions.
So, in your view, what are the biggest challenges to making advanced treatment like targeted drug delivery accessible to everyone?
I think that there are two main challenges. First of all, I've said that many times, I said it again, it's to prioritize health equity and equity in general over monetary or other power gains. That's the first challenge. Can we do that? The second challenge is to take into account and consider various differences. We have to start with the assumption that we're all different. And everybody's difference is equally important. When we decide whose difference will count as difference and cater for, then we start prioritizing, discriminating, setting inequalities. That we need to discuss first. Now, what we're experiencing right now is an international decline of public health systems. It's an international decline of even affordable healthcare. The present healthcare systems and policies are not likely to support universal access to targeted drug delivery. Despite the fact, and here it shows that the care system might not be as smart as a thing. In the long run, targeted drug delivery, medical innovation can reduce costs of healthcare and other societal costs. It will be great if we can fix problems without having to keep people in care units or long treatment with care providers that cost money, that people lose their jobs over this. It will be great. We will reduce other costs. But see, we're not willing to increase, to invest monetarily, economically, in the development and the delivery of innovation that will, in the long run, reduce economic costs and social inequalities.
So, according to this, there are a lot of, let's say, undeserved communities, people that cannot afford treatments, that often face barriers to access even the basic healthcare. How might this disparity be even more pronounced with advanced treatments that are suggested by nanomedicine and targeted drug delivery? I mean, they are already facing these barriers to access healthcare. Is this going to be even more pronounced after we move on to after we move away from the traditional medicine and we go to more advanced technological medical applications?
Any healthcare that costs more increases inequalities. Think about it. They will have, some marginalized groups, they will be left with the public healthcare system. And we all know what that means. And those who can afford nanomedicine or whatever else innovative medicine, they will be even healthier. They will even sooner than the other people. But they will live a better life to begin with. That will increase power differentials and control. See, we have to always put that in mind. Because when we control a healthcare system, and we do, if we have access to better medical treatment, we control better the healthcare. And we might even have the power to reduce resources from what is publicly available or available to many people, to different social groups, so that we can get better outcomes ourselves. Look at what's happening to our public hospitals right now. Good doctors, experienced doctors, well-known and established doctors leave the public healthcare system and go to private institutions. And the same examination, medical examination, you were able to get like 2 months ago in a public hospital for free. Now you have to pay 300, 500, 800 euros to get it from the same person. What does that mean? It means that a good resource. And why is this doctor living there? Because they're not paid very well, because they're overworked, because of all these other things. What does that mean? That we have removed a resource from a public hospital. This doctor is human capital, is resource for the hospital, and move this person to a private institution, a private company that makes money, right? A private hospital makes money. That's what they're for. A public hospital is there to provide health and care. So here's how we will reduce even further the resources of marginalized, underprivileged, under-resourced groups.
Okay.
I'm not arguing, see here, I'm not arguing against medical innovation, not at all. On the contrary, I say that it's a good thing and we need to continue in, developing better and better treatment that will be less painful, less suffering, all this. But if we're going to do that, we should do that for everyone, not for the few.
For sure. Do you think that the people that are receiving the treatments should also be educated? I mean, health literacy can play a very big role in treatment decisions. So do you think there is enough information and education available to the public, especially in marginalized communities, about complex treatments like targeted drug delivery, for example?
No, I think that there's no health literacy is one of the social determinants of health, right? That's for sure. And it has the potential for very positive implications for health. Now, the sources of literacy need to be carefully checked. And here we have a responsibility as the academic and research community, public policies, policymakers, the state, to educate people about the available treatments. Advocacy groups can play a very significant role in increasing health literacy. That is true. I can think of policies and even campaigns by advocacy groups that will target specific marginalized or under-resourced groups and go there and inform them, say, listen, there's this treatment available, this other treatment available, you can do this, you can do that. Those things have happened in the past and they work. We just need to find a way to talk to people and people will listen. However, again, if we educate people for available treatment and treatment is not accessible to them, it's just a moot point. On the other hand, increasing health literacy can generate actions for accessibility and availability. So if we learn about available treatments, then maybe we can get together and act as citizens, as concerned citizens, as interest groups, as whatever, to demand and maybe get access to those treatments.
People tend to get influenced about especially health issues by a lot of social, let's say, groups. Yeah. So we have seen this especially with COVID-19. There was a lot of controversy. What do you think that are the cultural and social beliefs that might influence how different groups can view these advanced treatments that are suggested by nanomedicine?
Well, you can't really, I mean, at this day and age and with all these social groups and all these social media and all that, unfortunately, you cannot avoid misinformation. It's almost a fact of life. There, I would say that it is the responsibility of those who have the knowledge to disseminate knowledge. We have to find ways to discuss the topics in a way that people can relate to the information we give them. There's a whole new science out there that is science communication. So there's a big debate among scientists, researchers, policymakers, I would say, about how we communicate science and scientific findings. We need to find new ways. Maybe have also try to get together with patients groups, for example. They do very good work. It facilitates very much the communication. Other social group, I don't know, consumer groups would be a way. Citizens, active citizens, groups of citizens, they need to get together we need to organize, academics, we have responsibility, and here's also a good example where we can work together, collaborate, scientists with expertise from various scientific fields. If we share information, then we can communicate to different people, different social groups. I would say, for example, that social scientists, we have a better way of understanding the language or the needs or the way to communicate information to specific social groups, or we have the tools to find out what kind of information they will be recipient to. So if we and those who develop the technology work together, then the technology can be better suited for the groups, and all the benefits or the dangers from the specific innovation, the specific technology can be communicated. And it is so very important that people know what they are faced with. In bioethics, in ethics in general, we talk a lot about informed consent. See, that's the concept. You inform people of what they need to expect. And then they will make their own decisions and choices. Okay? And no, I'm not advocating individual responsibility, which is not what I'm saying. But I'm saying that people have agency, and we need to respect it, because that's their agency that decides what they will do in their life.
Nice. Do you think that public health policy should have a role in ensuring equitable access to targeted drug delivery treatments for both men and women or different social groups?
Absolutely. Absolutely. It's political decisions. They need to make political decisions to distribute equitably the targeted drug delivery. And they need to be prepared for what's going to happen in the future. We need to sit down and think of regulations, of guidelines, of principles that would be implemented when we develop, deliver, the whatever innovation it is. And there, of course, we need to take into account all the possible groups that can benefit and the ways these groups can be benefited.
Okay, so what steps do you think that should be taken to ensure that targeted drug delivery research of future applications in health consider both sex and gender as critical factors? What are the basic first steps that we should follow?
For sex, gender, social class, education, income, rural, urban, for all these. First of all, we need to understand the content of these differences and be honest about the content of the difference and not biased. We should not make assumptions about what people in rural areas, for example, want and people in urban areas want, what men want and women want. We should not make assumptions. We should do research. We should listen and hear what the groups that we're looking for have to say. We need multidisciplinary, and I would say transdisciplinary, which means we need to include their citizens in our design and development of any technologies, account for all the differences, and see how they can be alleviated. I know it sounds very complicated, but it's not as so. And it's, if you want, it's liberating and empowering for the social groups. And I dare say it's empowering for the scientists as well. Because they will be able to see whatever they develop as an innovation, as a tool, as anything, how it positively affects the lives of people. Of course, policymakers should be there. Advocates should be there. So we have co-production and co-design of research and measures. What else do we need here? Plenty of money, public money. Public money that will be spent for technologies and for distribution of this technology to those who need it and cannot afford it.
Exactly. So to wrap up this very interesting conversation, what advice would you give to healthcare policymakers, scientists, advocates that want to address social inequalities while also advancing medical technologies?
Just only one. Make sure that social benefits, social justice, and social care is prioritized over profit and power. That's the only way to be done. Can it be done? I don't know. But I see it as the only way.
So, Professor, thank you so much for being with us today and for sharing all this interesting information. Thank you, everyone, for listening, and don't forget to tune in for our next episode. Goodbye, everyone.